Welcome to the deep dive. Today we're plunging into something that, well, it's really touching so many parts of our lives: energy, motivation, metabolism, just that overall feeling of vitality. I'm talking about testosterone. And specifically, what happens when those levels dip? When your T is low, life can just feel kind of flat, like the color is drained out. And naturally, the first thought might be, okay, quick fix needed. But hang on, before jumping to solutions, there's a really fundamental question. Low T, but why? Because understanding the root cause, that's paramount. Otherwise, you're just, throwing darts in the dark, hoping something sticks. So our mission today is to crack that code, to really get into the critical difference between primary versus secondary hypogonadism. Getting this right is absolutely key for your health. It's not just a technicality.
That's absolutely spot on. The impact of testosterone, it's huge. How you feel waking up, focus, even things like bone density. It's all connected. But the crucial point, like you said, is that low T isn't just one thing. There are different reasons it can happen. And knowing which reason applies to you, that's the absolute roadmap to figuring out the right path forward. So yeah, we'll explore these two main types today. Because telling them apart isn't just medical jargon, it's fundamental. It dictates whether you're actually solving your problem or maybe even going down a dead end.
Okay, let's unpack this then, this fundamental distinction. It boils down to where the issue starts, right? Is it the factory, the place actually making the testosterone? Or is it the command center that's supposed to be telling the factory what to do? Could you maybe elaborate a bit on that? What exactly are this factory and command center? How does that split define primary versus secondary?
Absolutely. Yeah, let's paint a clearer picture. Think of the factory as, well, the testes. They're the primary site where testosterone gets made. And the command center, that's up in your brain. Specifically, two tiny glands, but wow, incredibly powerful ones. The hypothalamus and the pituitary. Hypothalamus kind of kicks things off, and the pituitary then sends out the key stimulating hormones. Luteinizing hormone, FSH. So these two systems, brain and testes, they're in constant communication, like a feedback loop. And if there's a breakdown anywhere in that chain, either in the commands or on the production line, the result looks similar, symptom-wise, low T. But how you fix it, that depends entirely on where the problem actually is.
Right, okay. So let's start with primary hypogonadism, using that factory analogy. It sounds like the command center, the brain, is doing its job fine. It's sending out the orders, loud and clear signals saying, make testosterone movement. But the factory itself, the tests, they can't keep up. They can't respond effectively. So like the CEO is shouting orders, but the machinery is broken down. Is that the idea? What goes wrong in the testes?
That's a great way to put it, yeah. Biologically, in primary hypogonadism, the brain is sending out high levels of those hormonal orders. Those messengers we mentioned, LH and FSH. LH is the main one telling the testes to make testosterone. FSH helps too, with sperm production and general testicular health. The brain sees testosterone as low, so it ramps up LH and FSH production. It's basically yelling louder, trying to get the testes going. But despite those high signals, the tests themselves are, well, they're unable to produce enough testosterone. They're damaged or just not functioning properly. And this inability, it can come from a few common places. Sometimes it's genetic, like Klinefelter syndrome. That's where someone's born with an extra X chromosome affecting testicular development. Other times it could be direct injury, maybe surgery affecting the testes or something like testicular torsion, or even having a testicle removed. We also see it, unfortunately, after certain medical treatments. Chemotherapy or radiation can sometimes damage that sensitive testicular tissue. And of course, there's also just age-related decline. The factory, it can become less efficient over time.
Okay, that makes sense. So if you're getting blood tests in this scenario, what are the telltale signs? What would you see?
Right. The diagnostic clues are pretty distinct for primary. You typically see high levels of LH and FSH. That's the brain shouting, remember. So those messengers are elevated because the brain is trying really hard. But, and this is the key, you'd also see low testosterone. The factory isn't responding to those loud signals.
High signals, low output. Got it.
Exactly. And what that means for treatment, for your path forward? Well, because the tests themselves can't make enough testosterone, the usual approach is direct testosterone replacement therapy, PRT. It's not about stimulating the factory anymore. It's about supplying the product the factory can't make.
Just replacing what's missing.
Precisely. The goal is to get testosterone levels back into a healthy range, which usually helps a lot with symptoms fatigue, low libido, mood, energy. But it's generally a long-term thing because the underlying issue in the testes, the broken machinery, it's still there. It's replacement, not really a cure for the primary problem.
Okay, so it sounds like a direct replacement is the main strategy there. But is it always that simple? Are there times when, even with primary hypogonadism, TRT might not be the immediate go-to, maybe because of other health stuff?
Oh, that's a really important point, yes. While TRT is the standard treatment for primary, a doctor always looks at the whole picture, your overall health. For instance, if someone has, say, existing prostate concerns or certain heart issues, the approach might need to be more cautious. Different forms of TRT, different doses, maybe closer monitoring. And also, for younger guys or anyone concerned about future fertility, TRT is great for T levels,
Mm.
but it often suppresses sperm production.
Ah, right.
So that needs a very different conversation, maybe exploring options to preserve fertility before starting TRT or alongside it if possible. So, yeah, the diagnosis points towards TRT, but how it's done,
Uh-huh.
that's definitely individualized.
That's a critical nuance, thanks. Okay, let's pivot now. Secondary hypogonadism. You said this is where it gets really interesting. How does the story change here? Where's the breakdown now, and why is that shift so crucial?
Right, this is where it flips. Secondary hypogonadism. Imagine that factory again. This time, the factory itself.
Mm.
It's probably fine. The machinery works, the workers are ready. But the problem is the command center. That brain pathway hypothalamus, pituitary, it's just not sending the right signals. Or maybe not sending enough signal.
So the management is off, not the production line.
Exactly. The issue isn't the testes' ability to produce, it's that the brain isn't telling them to produce effectively. So here, the focus shifts completely to the brain's role. Those tiny glands, the hypothalamus and pituitary, they orchestrate so much. In secondary hypogonadism, they aren't signaling correctly. Maybe they're not making enough GnRH, which is the starting signal from the hypothalamus, or maybe the pituitary isn't releasing enough LH and FSH. Whatever the reason upstream, the message to the testes is weak or absent. And so the testes don't produce much testosterone, even though they could.
And what kind of things cause this brain signal problem? It sounds like it could be a wider range of issues.
It really can be, and that's why diagnosis is so vital here. For instance, pituitary tumors, even benign ones, can physically interfere with the pituitary gland's function. Head injuries, sometimes even ones that seem minor at the time, can affect these delicate brain areas. Chronic illnesses, a whole host of them, like kidney disease, HIV, inflammatory conditions, they can subtly impact brain signaling over time. And then there are medications. Opioids are a known culprit. High-dose steroids, too. They can suppress the brain's output of LH and FSH. And even lifestyle factors play a big role. Things like chronic, severe stress or extreme exercise levels or significant obesity. These can disrupt that central command system, too. It's quite a list.
Wow. Yeah, it really highlights how interconnected everything is. So many things not directly involving the tests at all. Okay, so given that, what would the blood test typically show for someone listening if it's secondary?
Right, so the blood tests here are basically the inverse of primary. For
Huh.
secondary hypogonadism, you typically see low or sometimes even normal levels of LH and FSH.
Low or normal? Why not high like before?
Because the command center itself is the problem. It's not sending a strong signal, so LH and FSH aren't elevated. The brain isn't shouting this time, it's whispering, or maybe not even talking much at all. And paired with that, naturally, you still see low testosterone. The brain isn't telling the testes to make it, so they don't.
Oh, or normal signals, low output. Okay.
Exactly. And this is why that distinction is so incredibly important for your treatment plan. The approach for secondary might be completely different. Instead of just jumping to TRT, the first step might be to figure out why the brain isn't signaling properly. Is there an underlying cause we can treat?
Like finding the root cause you mentioned earlier.
Precisely. Missing this could mean, well, you miss treating something potentially serious, like that pituitary tumor example. Or you might miss a chance to fix the problem without lifelong TRT. If it's lifestyle-related, say, obesity or severe stress, addressing those issues could potentially restore normal brain signaling and bring T levels back up naturally. That's huge. And in some cases, particularly if fertility is important, doctors might use medications like clomiphene or HCG. These don't replace testosterone directly.
What do they do then?
They work by trying to stimulate the brain to send the right signals, or by stimulating the testes directly. They encourage your body to start making its own testosterone again. The potential for restoring natural function is a really key difference here.
Okay, so bringing this all together, what does this really mean for you, the listener, if you're dealing with these symptoms? It comes back to that core message, doesn't it? Low T is definitely not one size fits all. This distinction we've unpacked, primary versus secondary, it's not just academic stuff for doctors. It literally dictates the whole treatment strategy. Like you wouldn't fix a flat tire by replacing the engine, right? The problem and the solution need to match up. Factor issue, replace the product. Command center issue, fix the signals or the reason the signals are off.
Couldn't have said it better. Understanding which type you might have is absolutely the key. We talked about the symptoms, the fatigue, low drive, brain fog. It's so easy to just think, I need T,
Mhm.
but rushing to TRT without that proper diagnosis, especially if it turns out to be secondary hypogonadism, you might be masking a treatable underlying issue. You can overlook a pituitary problem, or miss the chance for lifestyle changes to fix things, or maybe even miss an opportunity for your body to start working properly again on its own.
So you might feel a bit better on TRT, but you haven't actually solved the real problem.
Exactly. Imagine two people, both wiped out, low energy. One has primary TRT is life-changing. The other has secondary because of, say, undiagnosed sleep apnea severely stressing his system. TRT might help his T levels a bit, but fixing the sleep apnea, that addresses the root cause and could resolve the low T and improve his overall health dramatically. A proper diagnosis ensures the solution truly targets your specific root cause. That's how you genuinely get better addressing the core issue, not just papering over the symptoms.
And that really wraps up our deep dive today into primary versus secondary hypogonadism. We've dug into that crucial difference. Primary, it's an issue with the testes, usually see high LH and FSH. And secondary, that's a brain signaling problem, typically with low or normal LH and FSH. And the big takeaway for you, that distinction is absolutely vital. It determines the right path forward for treatment. Are you replacing something missing, or are you fixing the system itself?
And maybe that leaves us with a final thought for you to chew on. If you are having symptoms that make you wonder about low testosterone, don't just jump to assume the problem or the solution. Ask why first. It makes you wonder, doesn't it? What other areas of our health might we be applying a sort of one-size-fits-all approach to, when the real answers, the better answers, lie deeper? In understanding those subtle underlying mechanisms, really being informed, asking those why questions, that's what empowers you to make the best decisions for your own health.